Thanks for listening in, everyone. My name's Ali. Today I'm going to be talking to you about our experience in terms of analysing the survival paradox in an Australian setting. Colorectal cancer remains one of the leading causes of cancer-related deaths globally. In an attempt to categorise all these different colorectal cancers and assist with prognostication, the IIIA has developed a staging mechanism based on the TNM staging process, where stage 1 cancers are the earliest, stage 2 penetrate up to and including adjacent organs, stage 3 involve regional lymph nodes, and stage 4 involve distant metastases. Traditionally, it was thought the further the stage, the poorer the prognosis. However, several multi-center studies have actually found that stage 2B/C cancers tend to have a poorer prognosis than 3A cancers, or the so-called survival paradox. So the aim of this study was to look as to whether the survival paradox exists in an Australian setting. Specifically, we looked at 3 hospitals within our health district and attempt to determine whether any factors can predict or explain why this paradox exists. So we looked at 161 rectal cancers specifically in an attempt to control the location of the colorectal cancers, of which 91 was stage 2A, 20 was stage 2BC, and 50 was stage 3A. Now our median follow-up was just under 4 years. We looked at rectal cancer specific survival, and the 5-year survival was 79%, 51%, and 86% respectively, confirming the paradox. As you can see, 2B and C cancers have the poorest prognosis. We then did a Kaplan-Meier analysis that you can see on the right, and there was a statistically significant difference between those 2B, C, and 3A cancers. One of the biggest criticisms of the survival paradox has been the question as to whether we're understaging these 2B/C cancers, hence why their prognosis is poor. So we actually did a subgroup analysis where we looked at the number of lymph nodes retrieved intraoperatively and whether or not they received chemotherapy as a confounder. And even in the most favorable circumstances, where the 2B/C cancers actually harvested, or more than 12 lymph nodes were harvested intraoperatively, and they did receive chemotherapy, their overall survival was still poorer than the 3A cancers, so 71% compared to 82%. When looking at predictive factors as to why this might occur, we looked at various factors ranging from age, whether there's positive margins, whether they receive chemotherapy, and on univariate analysis, 3 factors were predictive, essentially, of overall survival or cancer-specific survival. They were the tumor stage, understandably, whether or not they received chemotherapy, which is why we factored that into our subgroup analysis earlier, and the preoperative CEA. Other factors, although not statistically significant, but were more common in 2B/3A cancers, was the size of the tumor, and actually the acuity of symptoms, which is an interesting phenomenon, because in the past, cancers that actually had a greater interval between the time of onset and the time of diagnosis actually were believed to perform better due to the fact that they're less aggressive cancers. So overall, our study confirms the survival paradox here in an Australian setting, which lends weight to the argument that tumour size, or the T part of the TNM staging mechanism, greater emphasis should be placed on that in the future with regards to prognostication of these cancers.